From the Baker Institute for Public Policy at Rice University in Houston, Texas. This is Baker Briefing. I'm Ed Emmett. I'm one of the fellows here at the Baker Institute. Baker Briefings try to tackle the timely, critical foreign and domestic policy issues of the day. Today's topic is particularly timely, particularly interesting, and that is America's youth mental health crisis. Over the past decade, there's been a rapid increase in mental health issues among young people in the U.S. Rates of anxiety, depression, self-harm, suicide, they all seem to have been steadily rising. And then we had the pandemic, which obviously had a huge impact. Since 2020, if the statistics I'm reading are correct, which I think they are, mental health-related emergency room visits among adolescents have increased 31%. Suicide rates among teenagers have increased 25%. So I guess the question is, what's driving this crisis and how can we do anything about it? How can communities respond? Before I introduce the three panelists, let me sort of set the stage a little bit, because in the public arena a lot, you get people who say, well, we just didn't used to report these things. But I don't think that's the right answer. I'm not a panelist, I'll let y'all answer that, but I know you hear that when you have statistics. They say, well, teenagers are always a little bit strange, and now we're suddenly saying it's mental health. So with that stage set, we're fortunate today to have three outstanding colleagues of mine here at the Baker Institute to kind of take on these questions and offer some answers. Dr. Rola El-Serag, Dr. Lillian Dendo, and Dr. Jan Lindsay, and I would ask each of you, when you get a chance, to say a little bit about what you do, keeping in mind the time frame we're under. So each of you brings a different medical practitioner's perspective on this issue. And I guess we're going to go to Lillian first. Start us off by providing some context for understanding what's the scope of this youth mental crisis.
So we are in a crisis, for sure. You gave some statistics, but I'd like to really reiterate some of them. 1 out of 6 of our youth right now have clinical depression. 1 out of 3 of our youth have clinically significant anxiety. 50% of our youth have elevated levels of distress that are not maybe reaching the level of clinical significance. And I just want to pause for a moment and say, okay, if we're in a room with 4 kids between the ages of 10 and 20, and you count 1, 2, 3, 4, 2 of those kids are suffering, often in silence, and struggling with significant sadness, anxiety, loneliness, pain, and silence, and not knowing how to cope with their thoughts or emotions. It's staggering to think that if you're in a room with 4 kids, 2 of them are feeling this way. And I really want to highlight that, because it's not someone else's problem, it's all of our problem. We all know someone who is suffering from this. The most alarming outcome of the rise of mental health problems is the suicide rates. Suicide rates, like you said, have increased 25%. They have tripled, though, among the kids between the ages of 10 and 14. Tripled in recent years. And again, I want us to pause and recognize that it's the second leading cause of deaths for our kids after accidents. So it's more than all natural reasons for death for our kids. That's staggering, too. So again, we are in an alarming time. Like you said, ER visits have increased 30% in recent years, and a lot of them are for suicide attempts, actually. Now that's step one. Step one is it's a staggering problem. To add to the problem, we have really major problems with access. So only less than 50% of these people will access treatment, actually. Less than 50%. And among this 50% of those will access treatment in schools. They're in crisis mode and they'll seek a school counselor or a mental health professional in schools. Only 25% will actually go to a mental health provider. So we have a big problem, really poor access to treatment. In fact, the delay between the start of significant symptoms and receiving treatments is 11 years. 11 years of suffering, decreased functioning, poor school performance, etc. Again, I think it's really important for us to note that for a significant proportion of our youth that are getting treatment. They're getting it in the schools. And by the way, there's a massive disparity among our minority and socioeconomically disadvantaged kids. The people that can afford treatment are generally high SES, socioeconomic status. It's very costly. We don't have mental health parity. We do not have insurance that covers mental health the way it covers physical health problems, so that's another problem. So there are clear disparities also with access to service. So given these things, the problem with access, the low number of providers, the big cost of mental health treatments, what we propose is starting to take a public health approach that would complement the medical approach, where we are actually looking at things from a prevention perspective and looking at it from the school perspective. Why are we not going into schools and providing core competencies on how to manage difficult thoughts and emotions universally to all the kids, so that we can decrease the disparities between kids and prevent the problems from becoming a crisis, actually.
Okay, well.
Yeah, and I'll chime in quickly about the trends, because I do want us to have this discussion recognizing that, yes, the COVID pandemic and the shutdown made everything worse, right? We were all suffering, but these trends started 10, 12 years ago. And so we're trying to understand what was also happening 10, 12 years ago. So I do research on the impact of technology, good and bad, on the mental health of both adolescents and adults. And I think we can't ignore that the rise in social media, the rise in, this kind of, rather than seeing each other in person, there's a lot of, and again, good and bad, but I think that is something that we need to recognize. It's not just the pandemic. This trend has begun years ago, and that kind of coincided with the increase in social media and a lot of online kind of living.
Okay. Well, Dr. Dendo set the stage, I think, very well. And Dr. Lindsay, thank you for chiming in. But going to you, Dr. El-Serag, one of the issues I think all of us understand, mental health for so long was treated differently from health. And I think a lot of us have fought that battle over the years, saying, mental health, brain's one of your organs just like a kidney. I mean, why is it separated? Do we still have this resistance for people to engage in mental health access?
Absolutely. I think the stigmas are still there. They are greater in some racial and ethnic groups more than others. Within the medical community, there's been a movement. For example, the U.S. Preventative Task Force has recommendations now for adolescents to be screened for anxiety and depression. And there must be a general sense by the medical community as well as our community in whole that, as you mentioned, that mental health is part of general health. And this is something that needs to be open to discussion, that we need to be speaking about every day. There needs to be a role for schools in maintaining and ensuring that we raise our children to be resilient and that they learn good mental health hygiene. And those things can be taught. But many people in our society don't feel like schools should be teaching those things. However, we do know, and we saw this in the pandemic, that because schools play such a role in regulating and providing a safe space for children, we can't ignore that aspect of their mental health. The impacts of the pandemic significantly stemmed from the fact that, children were not in school and they didn't have that safe space and they didn't have those services that they could access in the schools. So I would say that yes, absolutely, we still have a lot of work to do in this area, and I think that this is going to be an instrumental part of improving our ability to tackle this significant crisis, is changing the culture, changing the stigmas, and the way we think about mental health. And I do also strongly believe that prevention is key.
Okay, so since you mentioned culture, one of the main features of culture these days is social media. Is it good? Is it bad? Is it a cause or is it a potential solution? Jan, you seem to be nodding your head.
I think that when we talk about technology and adolescent mental health, it's a nuanced conversation because it's very clear that especially teenage girls, if they are engaging in social media, there's a strong link for depression and anxiety. 3 in 5 young women are clinically depressed, and they do report that this social comparison, going for the likes, they report that that's distressing. But I think it's important because we don't want kids to feel isolated either. During the pandemic, that was such a lifeline for young people. So I don't love this idea of social media as like one thing. There might be certain aspects of Instagram and these other tools that are harmful, but let's talk, let's have a dialogue rather than saying everything in technology is bad, because I do think it's part of the solution. So I think we just need to be thinking about thoughtful policies around this while recognizing this is a new landscape. And as a mom and a teacher and a mental health professional, we're anxious because we didn't grow up with, and so we're not always equipped to how to talk to kids about this. And that's where I think when we talk about these prevention and coping, have the conversation with young people, because it is an essential lifeline, but it's also clear that it's causing distress in young people's lives.
The U.S. Surgeon General, released a special report with some warnings in it. I think that the evidence is not out yet. And we still have a lot to learn about the impact of social media. But some of the highlights of the report is that different children will engage differently with social media. And that is a big determinant of the effect of it. So it's important for parents to understand how their children are engaging and what type of social media they're engaging with. So, for example, engaging in social media that promotes discrimination or bullying or sexism or violence, obviously those are going to have profound negative impacts. Whereas social media, as Jan was mentioning, can have a very positive effect on children. So it's important for parents to be involved and understand. And then, of course, the individual child, what sort of coping skills they have, what sort of personality, genetics, all of those things will also impact how they interact with social media. So we know that as of now. The other important thing to understand about social media is that it often interferes with sleep and physical activity. And we do know that those things are critical to good physical and mental health. So that's something to think about when parents are considering the impact of social media, is that you really want to make sure it's not impacting sleep and physical activity.
Okay, so Rola, I'm going to keep going with you here for a minute. We've all talked about the problems. What's the answer? Obvious question, what can we do about it? And we'll just go down the line and let each of you take a shot at that.
Well, there are several major issues Lillian kind of highlighted. I think I'll talk a little bit about workforce capacity and the burden on the healthcare system. You may ask us later, but we are not equipped to handle this crisis, not even close. We have a significant shortage of mental health providers and child psychiatrists, psychologists. Schools are in crisis mode. School counselors are not able to provide adequate services. And emergency rooms and primary care physicians and providers are overwhelmed and burdened. That brings up the issue of education, because emergency rooms are traditionally not a good place for mental health care, and primary care traditionally is not as comfortable and not well trained in the area of both diagnosis and treatment. And so that brings the issue of education. We need to start thinking about policies geared towards providing better education to our emergency workers and our primary care workers to be able to handle that crisis. But as far as workforce capacity, there's got to be more incentives for people to go into these fields. We have to think out of the box to employ other types of providers that can provide services for crises and for long-term treatment for mental health. And so we can talk about that when we talk about some of the policy changes that need to be made. But I'll comment on that, and I'll let the other two talk about treatment and intervention.
I have several thoughts on what needs to be done, and I think Jan and I have talked about this extensively, but what Rola talked about, Dr. El-Serag talked about, is the medical model approach. These are the people that are in crisis, going to the ER, going to primary care, going to a mental health professional. So that's definitely one approach. I think we need a multi-tiered approach. We need to be approaching this from multiple phases. And so there's that medical model approach. What does the public health approach look like? That's a prevention, population-based approach. And so this is providing low intensity services to everyone in the population. And so that will complement the medical approach, but it also prevents people from getting into crisis, hopefully. And schools, again, we're harping on this thing with schools, but it is a place where everyone has equal access to things. We're teaching our kids math and English and science and social studies. And if they're not functioning well, they're not learning these things. Why are we not teaching them how also to cope, how to develop competencies in their emotional, physical, behavioral health, right? It's a competency just like math, English, science, etc. Without it, they can't do those things effectively, actually. And we have decades of research as clinical psychologists which have outlined what are the core competencies for resiliency and mental health. They have not been translated into practice, however. You know, there is social emotional learning in schools right now. It's not evidence-based, it's not uniform. And so we need to do something about that. So that's one thing. The second thing I would say is that we need to actually integrate mental health services into different settings. It's not just in the medical community, it's not maybe just in schools, but other places. You know, we were talking about where do people from different cultural backgrounds feel comfortable? Where do they trust going? Let's integrate them into those areas. We definitely need to do something about mental health parity with physical health parity. There has to be something done about how insurance covers mental health services, because it is cost prohibitive to go to a mental health provider for anyone who's not middle to high class, actually. So we definitely need to work on the parity issue.
I think you're hearing right now we have this huge need and we don't have the capacity. We don't even have the capacity as mental health clinicians to meet the need today. And this trend is going to continue. And so we've got to get creative. We've got to do more innovative approaches. School-based interventions are effective, but like Lillian's saying, they're not always evidence-based. They're not always making that, what have we studied, and going into schools or going into after-school programs, normalizing mental health treatment. We are all struggling. We all suffer. Kids need to know that. Adolescents need to know they're not alone. And we need to do it so that they can talk to each other, because we really don't have the keys to the kingdom. We know what works as far as coping and tolerating distress. We also don't want kids to feel like, okay, I'm anxious, there's something wrong with me. No, we all have anxiety. We all struggle. We all feel sad sometimes. And for them to be with each other, but also with somebody who's been trained in an evidence-based treatment. Because the old way of doing mental health that we were trained in, one session by one person every week for 12 to 16, we can't do that anymore. We've got to start, and people don't want it that way. Young people want us to get creative and integrate technology, but I won't say that anymore.
Well, let me take this from a total layperson. Adults, if they're feeling out of sorts, they can go to friends. But if you're 12 years old, your peers don't really know any more than you do. So what makes it so different for adolescents? And how do we deal with that? And frequently, I'm going to add one more thing, you know, the parents aren't always going to be on board. They're going to say, well, they're just going through a phase.
Our friends don't always know what to say either.
No, I know that.
But I do think if you have somebody, a psychologist, a counselor, somebody leading like a group with this evidence-based approach, kids can be supportive, because a 12-year-old needs to be supported by other 12-year-olds and not to feel alone.
If you think also about how difficult it is for us as adults to communicate, you know, and regulate our emotions, you can imagine an adolescent who is, you know, bombarded with so much change and hormones and confusion, and to be able to discuss that with friends, I think would be even more challenging as an adult. And then teenagers and adolescents are very self-conscious, right? They're not, and so are adults, because there's a stigma with mental health, right? People don't want to open up and talk about those things. And I think that's exaggerated amongst adolescents as well. So there's a lot of barriers that they face.
I think related to that, we do need a public campaign, like education campaign. We do need to transform how mental health is viewed and understood. I mean, the way it is viewed and understood now is so contrary to reality, actually. I'm going to be a little direct here. Raise your hand if you've experienced anxiety. It's part of the human condition. Raise your hand if you've had sadness that like lasts a week at a time. It's part of the human condition. If you have a pulse, you will have pain and sadness and suffering. And so let's stop pretending like it's them and not me. And then I won't feel as alone as a child. I won't feel as alone. And there's someone there to equip me with how to deal with this. Who has had the thought, I'm not good enough? Please raise your hand. I'm not smart enough, I'm not good enough. We all have those thoughts, but we think we're alone and we think there's something wrong with us. We need a public campaign, education campaign, normalizing this and saying, we have the tools for this. We have decades of scientific research teaching people how to cope with this. And if we're honest about it, it really takes away a lot of the pain. Because if you feel alone, that just adds pain onto pain.
And this is a public health crisis, so why leave it just to the parents? That's going to be dependent on the parents themselves.
Who are suffering themselves
exactly.
often.
And who don't have the skills. When we have the skills and the scientific evidence behind it, and this is a public health crisis, then we should be offering it to everybody uniformly.
I know I'm sitting here talking to three health professionals, but the pandemic also sort of put us in a circumstance where a lot more people now don't automatically trust the medical profession. So how do we overcome that? That's a separate question, but we could talk a long time about this subject. So let me sort of wrap it up. If each of you will, and this is going to be difficult, but I'm going to start with you, Jan. I'm going to put you on the spot. What one thing could help the most from your point of view?
I think conceptualizing mental health for young people in kind of what Lillian and I were trained in this biopsychosocial model, which is like, how does your genetics interplay with your mental health, which interplays with your family system. But I would add the technology piece, because that really is causing distress for young people. But it's also a great tool to reach people. Video telehealth, apps, these things that can be very helpful. And so I think rather than it good and bad, I think we need to be conceptualizing adolescent life with that lens of biopsychosocial technology.
You can probably guess what I would say, but I really think we need to integrate wellness programs into the schools. Start early, start in 10-year-olds, 11-year-olds, 12. It should be part of the curriculum where uniform evidence-based classes are done so that these kids are taught early on. When they have these thoughts, what do we do? When we have these emotions, because when you have these emotions, you want to run. When you're anxious, you want to run, but actually running exacerbates the issue. It feels good in the short term. It just doesn't work in the long term. So teaching our kids this,
infusing it
into the system, I think is the one thing I would do.
Similarly, I think we need integration of a comprehensive plan that involves community, schools, legislators, medical community, and all talking to one another so that we are not separating, well, there's treatment here, there's the biological model, and then there's schools, and everybody's kind of siloed and not working together. Because I think that the most impactful approach for our adolescents is really going to be that they are receiving comprehensive care at home, at school, with the pediatrician, kind of everywhere that they are, along with public health campaigns, for example, so that there's changing stigma. So I think that from the standpoint of policymakers, there needs to be more unity, more communication between all of these different players to integrate a plan that can impact children from all aspects of this issue.
It's a challenge. And in your last comment saying at home, well, a lot of homes aren't a very good place for that to occur. And a lot of schools may not be either. So I do think programs like this are very useful because they get people thinking about mental health, because this issue is important to me because I grew up with a father who had a panic disorder, couldn't be alone. I didn't know that till I was 17 years old. I thought he took me everywhere with him because he liked me. But no, he could not be alone. And so every family probably either has a family member or knows someone who has a mental health issue. And I really appreciate the time you've taken today because a lot of these mental health issues start when they're young. And by the time they get older, then it might be too late. So thank you very much for being on the panel. Baker Briefing is brought to you by the team at Rice University's Baker Institute for Public Policy. This episode was produced by Victoria Jupp and Shannon Moriarty. AV production was led by Kevin Young and Andrew. Many thanks to the Baker Institute production interns who assisted with this episode, Sarah Davidson and Lisa Jacob. The Baker Institute for Public Policy provides meaningful policy analysis on the most critical challenges facing Texas, the U.S., and the world. It is a nonprofit, nonpartisan policy research organization based at Rice University in Houston, Texas. To learn more, including how you can attend a live podcast recording on the campus of Rice University, visit us at bakerinstitute.org. Thank you for listening.